we could discuss hours and hours, of course, and same thing for the surgery. And by purpose, I will try to shorten this presentation because it was not the purpose today to focus on the surgery, because you know that the main treatment is physiotherapy and conservative treatment. And you see the kind of key message that you got during this presentation were very interesting, especially about the shoulder instability. And you know, maybe it breaks some usual opinion and belief. You know, when you say, discuss with someone, oh, the throwing shoulder, yeah, you have to treat the shoulder instability. It's not exactly like that. And you will see with the presentation of Dr. Courage that it's quite different, and he will focus on that. So briefly, if we have to talk about what kind of treatment, what kind of surgical treatment we propose to the throwing shoulder, I would like to ask you for the, do you have the pointer? I would like to ask you to look at this very nice paper, one of the only one in handball and done like that, the team of Christian Gerber in Switzerland, and they compare athletes throwing shoulder, athletes non-throwing, and dominant shoulder of volunteers. And this study, even the number is very low, it's very interesting to have an idea of what we are treating and what we must be aware about the surgical indication. So you know that in the athletes throwing shoulder, the average, they found an average of 7 abnormal MRI findings per shoulder. They did MRI for everybody. In this group, group 2, they found 4, and for the dominant shoulder normal, an average of 2 abnormal findings. So the first message is, okay, in this room, even if your shoulder is okay, your dominant shoulder, maybe you have already 2 abnormal findings. Do you need to be operated? No. So there is no reason that you should do that. But even though, if you're talking about this athlete throwing shoulder, if they have 7 abnormal MRI findings per shoulder, it means the probability to find abnormalities in your players is very, very high. Does it mean that you have to operate them? Sure not. So it's a very important message from this paper, and I was very happy to find that and to study this paper, because in the majority of the case, what they found cuff pathology and some sign of posterior superior impingement and slap lesion. And in fact, if you look at for people who have experience with throwing shoulder, and especially handball shoulder, this is a summary of the pathologies that you can find in overused shoulder. And more interesting is the fact that, okay, they found some partial rotator cuff tears and superolateral osteochondral defects. So they found partial calf tears, and we'll come back on the next slide, and superolateral osteochondral defect. And probably some people can confuse about that. You know, if you look at this lesion, in 43% they have supraspinatus lesion. Imagine 43% of these people had a supraspinatus lesion, partial tear. We don't operate them. So it's very important in a large percentage. 27% in infraspinatus and 17% in subscapular. And the very interesting thing is this superolateral osteochondral lesion, which is 57% of the case, which is very different from a heel sac lesion, you know, the lesion that we found in anterior shoulder instability. And probably, and this is this picture I will show you are from handball player high level in Qatar, and you see that this lesion, you can say, okay, it's a heel sac lesion, it's an anterior shoulder instability. No, if you look at cautiously the image, it's completely different. It's a bruise, bone bruise, there is no heel sac lesion, it's not exactly at the same place, so it's a specific lesion, probably to the posterior shoulder impingement, posterior superior impingement, described by Walsh and already mentioned by Rod. Now this is important to make the difference with the heel sac lesion. And what kind of lesion we can find in these different handball player first league? You know, this articular side partial tear of the supraspinatus, this lesion which is still a superolateral lesion, this posterior superior impingement. And again, this kind of lesion, which are partial interstitial or intermediate lesion, or sometimes superficial. This lesion on the insertion of the supraspinatus with some geode, and this obviously this slap, and it's clear that we found some flat. We find some flat. And Rod tell you what is the probable diagnosis and explanation of this slap lesion. So it's very interesting in this study as well, because they try to correlate the clinic with the MRI findings. And only 37% were symptomatic. Also, 93% of the throwing shoulder had abnormal MRI findings, an average of 7 abnormal MRI findings. So in other words, when you look at the MRI, and you should not look at the MRI before to examine the patient, but if you look at the MRI immediately like that, say, this guy, sure, he has pain, he has disability. Wrong. Only 37% were symptomatic. Okay? And in addition, on the other way, symptomatic shrugging shoulder did not have more rotator cuff abnormalities than pain-free asymptomatic shoulder. This is very important. So patient coming from with a painful shoulder, okay, symptomatic shrugging shoulder, it doesn't mean that you will find this kind of more lesion than for people who are pain-free, which is very surprising but very important for us as clinicians. So in clear, there is a very poor correlation between symptoms and abnormalities seen on MRI. And I would like you to remind only one thing from my presentation is this poor correlation. So from this idea and these clinical findings and this information, you know why we must be very prudent when we talk about surgery. And believe me, you are not obliged to believe a surgeon when he is telling you you must do surgery. But when a surgeon tells you don't do surgery, it doesn't work, believe him. Shoulder surgery in the overhead athlete, and this is one of the conclusions, should be evaluated seriously and should not be based predominantly on imaging findings. So in other words, it's another way to say, like our master and mentors told us when we were a student, we don't operate MRI, we don't operate X-ray, we operate a patient with symptoms. So it's a combination of clinic and MRI finding. So just to show you the kind of, briefly, because you see that it's not the main thing, but briefly, you can do a simple debridement, you can do cuff repair, you can do slap repair. Different surgery have been described, posterior capsular release, even anterior capsular application for those we believe that it's micro instability. Even humeral derotation osteotomy, because you know Rod told you that there is a problem with the humerus. To be honest, all the people who tried that step back because it's a very big surgery with a lot of mobility and with no big difference in terms of result. Or even posterior superior glenoid resection. Some example, for example, this one is a right shoulder. You see the biceps here. You see the inferior surface of the supraspinatus. You see this flap, typical partial articular side supraspinatus tear for a throwing shoulder. And you see the lesion can be even quite deep. But in this case, the choice was to do only debridement. And you see here the debridement is something which is quite simple, and the patient can go back to the physiotherapy immediately after. Doesn't mean go back to play, unfortunately, very quickly. But you know, a debridement, it means you clean up, and you hope that you will have a sort of healing process, and you clean up like that when the lesion is very thin, very small, and you don't have nothing really to repair. You have some other typical case, and this one is rare but it can happen. I've operated some of them like that with a complete tear at the end. You know, the posterior superior impingement is so important that at the end the partial tear becomes a complete tear. So you have to evaluate the lesion, and then we use this kind of system of arthroscopic repair. We put anchors in the greater tuberosity, and we pass a suture to restore the footprint of the attachment of the supraspinatus. There is here, for example, another example where you can see this is a right shoulder. You see the biceps here. You see the lesion of the supraspinatus, which is not good, very good. We put absorbable anchor in the greater tuberosity of the humerus, and then we pass a different suture, and we do what we call a double row repair of the supraspinatus by using special suture, very strong, allowing for you, physiotherapists, to start quite quickly the physiotherapy in order to avoid any, to lose time. Even I will show you that, which is very anecdotal, but you know, when there is a posterior shoulder impingement, some people propose to resect the posterior rim or wall of the glen. I'm not sure it's an anatomical technique, but you know, just to show you that we are so, we have so few good technique to treat this throwing shoulder lesion that sometimes we even propose some special surgery. But at the end, Okay, I can show you again this slap lesion before to conclude. This is a slap of the right shoulder. You see that the superior labral anterior-posterior, the superior labral is detached. It's a slap 2 with the biceps tendon attached on it. And this patient with a degenerative slap, superior labrum, and this patient developed this slap lesion after repetitive throwing, and we can reattach like with same type of anchor like in supraspinatus. You know, we reattach the posterior part, we will attach again the superior part, anterior part. It's quite difficult to do because you are always a compromise to find how to retension the biceps enough to be normal and not too much, because if you tension too much the biceps, you know that it can provoke some postoperative pain. So to summarize and to be very honest as a surgeon, within this different technique, except when we have to repair something which is really damaged like cuff or slap, our attempts to treat the posterior shoulder impingement surgically, honestly, we are quite disappointed so far. So probably, except for a very true lesion like slap or a cuff tear, full thickness tear or this kind of thing, the debridement, cleaning, or all this kind of thing are quite disappointing. And we believe that to propose this kind of surgery, except again, I repeat, for the acute lesion or a really true rupture of the supraspinatus or slap, it's obviously better to try a conservative treatment before to propose a surgical treatment, if we propose a surgical treatment. Thank you for your attention. If you have any question about the surgery of this, and then we will talk about the anterior shoulder instability. So about surgery that we perform to try to improve the posterior shoulder impingement or the throwing shoulder athlete lesions. Any surgeon in the room? One surgeon here. Do you have the microphone?
Have you the experience of biceps tenodesis in a throwing athlete?
Yes, and this is a good question because we didn't have time to develop this kind of thing in this short session, but you know, probably for those who are not comfortable with that, there is a controversy these days, these last years, about the repair of a slap versus tenodesis. Because for some people, biceps is very important in the throwing shoulder, probably. Some others, they say, no, we can remove, and I see my colleague doing, we don't know. And to be honest, there is no evidence. So as the treatment of some slap lesion is not very satisfying because sometimes we have some residual pain or recurrence, some people have proposed biceps tenodesis immediately. In my experience, I prefer to use, to first repair the slap because I'm a biceps killer like any French surgeon, as you know, but after 50 or after 60, when we are talking about athletic population, I believe that probably the biceps have a certain role in the coaptation of the shoulder. I'm not sure, nobody is sure, but at least we can try to repair the slap, and if it doesn't work, we can move for the second surgery with biceps tenodesis, which works very well. Probably we can be afraid about loss of strength, even if there is no evidence about that.